Morning to all of you in virtual land, as well as we have a room full right here. And I love building our global community, and I really appreciate looking at the geographical map. We have plenty of people in the United States by the size of the bubble, Canada, Europe, Asia, Africa, and no one in Australia at the moment. Anyway, we're really pleased to have Jon Daily here with us today. I was at a conference last year, a CADC conference in Sacramento, and I love interpersonal neurobiology, and it took me probably 2 months to be able to say that very smoothly. And he was speaking about it, and it was almost like poetry, and I thought he makes it understandable. Talking about the triune brain, I think that's a great accomplishment to be able to speak so clearly about such a complex topic. Anyway, within the past decade, I know I keep talking about Dan Siegel, the Mindsight Institute in UCLA, and all their research that they're doing. There are many followers of his. There's Dan Siegel, he's written Mindsight, The New Science of Personal Transformation. He's also written The Mindful Therapist, The Developing Mind, and his latest, with his teenage son in mind, I'm sure, was Brainstorm, The Power and Purpose of the Teenage Brain. So another thrilling aspect to this research is that now we can understand the relationship of brain chemistry in the addiction process. In 1978, Hans Selye defined addiction as a physical disease, and this disease concept was more or less ignored by society. Addiction, it seemed to be in the hands of degenerates or morally flawed human beings. With the advent of this new research in interpersonal neurobiology, hopefully man's perspective will change, and hopefully it will shift to a much broader arena and understanding where addiction can be viewed as a dysfunction in brain chemistry and possibly the attachment system. Interpersonal neurobiology of addiction is one of the most comprehensive models for understanding addiction today. It illuminates that there's no distinction between addiction and mental health, no separation in relationship between psychology and neurobiology. Jon Daily is a renowned author, professor, and clinician, and he's going to illustrate how the above systems work together, as well as explore some concepts such as attunement, resonance, and secure attachment, and how that influence and affects one's emotional, psychological, and neurological development. I'm not going to talk about the emotional regulatory systems as well, but it gets very complicated. Now a little bit about Jon Daily. I know he is a licensed clinical social worker. He works in the field of addiction with adolescents and young adults, as well as their families. The clinical director and founder of Recovery Happens Counseling Services. He specializes in addictive disorders and dual diagnostic issues. He's written a couple of books and has been given numerous awards. He's the author of How to Help Your Child Become Drug-Free and The Pathological Relationship to Intoxication and the Interpersonal Neurobiological Underpinnings. Please welcome him. Thank you.
Thank you. Well, thank you. I'm really excited to be here. This is one of the first times I think I've done a presentation that 75% of the audience is somewhere else. So hello to all of you that are somewhere else out there. That's a tall order for me to cover in 90 minutes and 30 minutes of questions and answers, but I'm going to do my best. It's a topic that is dear to my heart. What I'm going to talk about today is I'm not just coming from a theoretical perspective. It's stuff that I'm doing in my program every day and teaching the staff that work for me. So I'll just get right into it. And what I'll say also that Dr. Louis Cozzolino teaches at Pepperdine here in Irvine, and he's one of the fathers of interpersonal neurobiology as well. And he endorsed the back of my new book, so I'm grateful to him for that. So what is interpersonal neurobiology? Many of us have an understanding already of neurobiology slightly, at least in terms of neurotransmitters, that Cell 1 fires to cell 2, and the space in between the cells are called the synapse. And what I'm talking about and what we're learning from the literature in interpersonal neurobiology is I'm the end of a cell, you're the end of the cell, and the space in between us is the social synapse. And that piece right there is an important piece that we're going to talk about. So the social synapse is that me as Jon Daily, here, a person in this room, you in this room, there's a way in which we're co-regulating each other's neurobiology right now. And so what I'm going to do today is by the time we're all finished up, you're going to be really connected to the effect of relationships in your life. It's actually an introspective study in addition to a clinical therapeutic application. So we're going to look at that more closely, and I'm going to flesh that out. What happens within relationships, my argument is this. Underneath addiction, I get the disease concept. Actually, you mentioned the person's research and the disease concept. It was the researcher before that, Dr. E.M. Jelnick, who discovered that alcoholics progressed, had 31 symptoms, all relatable to any addiction with except of one of the symptoms, which was specific to alcohol, which was a decrease of tolerance over time. And then in 1957, the American Medical Association then took that data, said it meets the criteria of a disease, it has symptoms, it's progressive, and if left untreated, it can be fatal. And that's what really influenced the AMA, later the APA, and then the World Health Organization to adopt it as a disease. Now, I get the disease concept. I've taught it inside and out. I'm in recovery myself. I get that. If I do all the introspection and all the work in my life for the next 20 years and then I go out and start using it again, it's going to have the same effect. But what I'm here to say is that I think that there's more to this equation than that. I think if we start drinking a glass of mercury today, we're going to have symptoms. It's going to be progressive, and left untreated, it's going to be fatal. So I think there's a way in which the disease concept is extremely helpful, but also limits us in our scope. And I want to just kind of validate us today in some ways, and then stretch us in some ways in terms of our knowledge base. My belief reading through the data is that stress is the enemy for addiction, and stress is the enemy for most mental health issues. And so the fancy word in the literature for that is affect dysregulation. Inability and vulnerability to manage stress, to manage boredom, to manage depression, to manage anxiety. And so then that's what I believe is underpinning addictions. Then what underpins the development or the breakdown of somebody's capacity to manage stress or affect dysregulation? And my argument is that it comes down to relationships. That's one piece of it. There's genetic vulnerability. There's a lot of things, but this piece that I'm going to speak to today are relationships. And that's what we've learned from interpersonal neurobiology, is how attachments and relationships build or break and construct regulatory systems in the brain. This is just an illustration from Dr. Alan Shore's book, Affect Dysregulation and Disorders of the Self, to show really the argument that I'm going to make today, that there's no separating neurobiology from one person to the other. In this illustration, if I were to read to you the text that surrounds this, it would show that this child's orbital medial prefrontal cortex, which is right on the right side behind the right eye, is being developed from the caregiver's orbital medial prefrontal cortex behind the right eye. Now that's complicated, and I'm not going to go too deep into that, but it is at all times there's a neurobiological resonance and dialogue occurring between the two. And if you put the caregiver and the child under an fMRI at the same time, it's the same centers that fire. When we're in an attuned, truly attuned relationship with our client, feeling them and feeling felt, where they're like, wow, you really get me? They have this experience. And we're having the experience, there's nowhere else I'd rather be than sitting in this relationship right now. Put us under an fMRI, the same centers of the brain fire. So what interpersonal neurobiology has done, really, is put some science to the old school work from attachment theory. So Bowlby, the father of attachment theory, I would argue, states and this is how we start to look at the development of personality and relationships and structure in the brain. Attachment is a biological imperative. We must bond or attach for better or for worse. We need to attach to our caregivers. And then the parts of our personality that are not allowed into the attachment relationship get split off from us. And that's the start of fragmented self. It's the start of codependency. Those pieces that we have to split off from of ourself takes a lot of psychological energy to keep at bay, to harbor aside. So my insecurities, my parts of myself that I see in myself and feel in myself, but I don't live in a relationship where people see it and mirror it and honor it and allow it, so then therefore I have to kind of do something with that and make it go away. And because they don't have this, then I feel crazy because I'm the only one. And therein lies some of the underpinnings of insecurity also. To form secure attachment, some things are needed. And that is consistency. So here's where we're going to start to get, I'm going to start beefing up the complexity of how we get built. And I mean, for therapists, we're working with people all day long. And if I ask the question, what is the mind? It's hard for people to come up with an answer for that. How would you talk about your client or your patient's psychological structure, their psychological architecture? And that would be hard for a lot of clinicians. And my argument is we need to have a sense of exactly where each client is with their psychological architecture, because that's what's going to inform our understanding of them and certainly inform our treatment plans. Beyond get clean, stop using, go to meetings, don't put drugs back in, do some nutrition, triggers, what are your triggers, people, places, things, and emotions. You know, that's super important, but there's so much more that we need to get towards wellness. And I know in my program, my idea is not about sobriety. It's about sobriety is the first piece of the puzzle. And then the next couple of years, not 7 sessions, not 8 sessions, which some insurance companies want to dictate, it's about wellness, which takes a long time. I mean, you take a client that has a narcissistic personality structure, a borderline personality structure, histrionic personality structure, you know, broken neurobiology, broken ability to negotiate relationships, certainly broken ability to regulate their own internal dialogue, their own internal affective states, and to change that takes multi-years, not just 1 year, not just 2. It's usually up to about 7. So back to secure attachment, so we can prevent all those personality structures that I just defined. We need in an attachment relationship, I'm just going to go basic real quick and then we'll advance it. We need consistency. So when little babies are born, they cry out. They say, I'm hungry, I need to be held, I need to be fed, I need to be played with. And what happens that's so subtle but so profoundly important is that when the caregiver mirrors, I see you're hungry, I see you're happy, I see you're sad, I see you need to be held. What happens right there in the beginnings of psychological, neurobiological, and relationship architecture in this child are the beginnings and the blueprint for what's going to happen next. So when the caregiver responds with warmth and consistency and attunement, what starts to develop is a lot of things. So first of all, trust versus mistrust, which we talk so fast about in developmental psychology, this piece of trust starts inside. The baby, the person, learns that I can trust my own internal experience, my own internal physical experience, and my own internal needs, wants, and desires. Because when I call out to my caregiver and ask for my needs to be met, and they're met, I learn it's okay for me to trust what I feel inside. And it's also okay for me to trust other relationships, to turn to relationships because they're soothing me. So now it's trust versus mistrust, that first stage that Eric Erickson talked about. I trust myself and I trust others are going to turn to me and soothe my needs. Now that's important because addicts are do-it-yourselfers. They're not people that say, I need help. They don't ask for help. So what happens in just these little micro interactions is now trust versus mistrust is built, approaching relationships versus avoiding relationships is built, dopamine systems are built, norepinephrine systems are built, and I'll get into those in just a bit. But I just want to start with trust versus mistrust, approaching relationships versus avoiding relationships. But for the caregiver, it's not just responding consistently to the child's needs. Warmth has to be there. So when my son Dylan was born and my daughter Liberty, and they're like crying out because they need their diaper changed, I can't just walk up to them and go, diaper's changed. Did I provide for their needs? I did. You're hungry? Bottle. Did I provide for the needs? I did. But you all have a visceral experience of something's missing. And the warmth piece needs to be there. That warmth piece is building that internal structure that I've been talking about, and I'll flesh out more as we go. Attunement is probably one of the hardest things for people to really wrap their self around, because it's an experience, it's not an intellectual concept. If I attune to my clients, if I attune to my children, that to me is more of a diagnostic assessment, a diagnostic tool than the MMPI. When my gut is telling me something, when I figure out how much I need to slow down, and I slow down a little bit more to get into their rhythm, to get into how they're saying it or how they're not saying it, or their sense of anxiety or joy or whatever's going on, and that's empathy. Attunement is I let it inhabit my own body. So now, when the father is talking to me, now I'm going to shift it to a therapy session that's coming up for me that I've had recently. Father lost his son to an overdose. There's empathy. What would that be like? Really trying to wrap my head around that. But the attunement piece was, I'm going to go inward and feel what it'd be feeling like to get a call right now that I just lost my son Dylan. And you know what happens? I'm feeling it, and I'm sad, and I'm tearing up. And I look to the dad and I say, is this what it's like for you? And I know that I'm not even close to what it's like for you. And the dad's like, yes, you get me. That feeling of felt is important. It's not just, so you've lost your son and child, and I can't imagine what that would feel like, and I've worked with a lot of clients who've lost their children, on and on and on. But being able to sit, which is really hard, to sit with that then allows the resonance to occur where this person can go, you feel me, now I could be unstuck and start to flow with whatever my healing process is. And there's a lot of literature and research around that. But the concept of attunement is when it inhabits you and you let it inhabit you, and then you stop looking at them at some point as to what cues they're sending, and you just go inward. And so that's different from empathy. I'll work with families on this. I seem to draw this dynamic in my program where I have these super dismissive, avoidant dads. They're just like, whatever, no big deal, kids will be kids, boys will be boys. And then I have these and this I'm grossly generalizing, but it's pretty common, super sensitive, anxiously intrusive mothers. So they're like, where have you been? Son, where have you been? Daughter, what are you doing? What are you doing? What are you doing? What are you doing? And then dad's like compensating for that dynamic, like, well, I don't want to just, add to the, the anxiety for our kid. So he's pulling away over here. And then mom's feeling like, well, dad's not on board, so I need to get more anxious, and, all that dynamic's happening. And so then I'll start to work with them to attune to each other. And I remember a session I had recently with this family where I asked the mom to attune to dad around son's addiction, which was pretty, a bad addiction. And she sat there and looked at him like, okay, you, I think, are feeling worried. You're scared. And we had to, but that's all intellectual from the neck up, and so that's not it. And I said, I want you just to stare at him for a while, breathe, slow it down, quit trying to perform, and think about dad is doing everything he can to help his son, on and on and on, who he's seeing really go downhill, and how do you just feel that in your gut as, and speak to that. And so it comes forward, and all of a sudden the vibe just shifted from all this I'm thinking this too. I feel it, and then, starting to connect. I'll give you some examples of me attuning with clients in family sessions later on. Mentalizing is another structure, another piece that happens that's not talked enough about anymore in psychology, but mentalizing is a very important piece to what needs to happen. So when a child forms, because we're talking about secure attachment, part of a child forming a secure base is that the child has a sense that you're inside of them. And more importantly than that, that they're inside of you. So separation anxiety is this. You drop the kid off to preschool at 2 years old, and then the kid cries, and then at some point soothes through it and turns to the teachers there and other peers and gets regulated, puts themselves back together, and they go forward. Because they've mentalized you, and they're also knowing that they can utilize those other relationships. They've learned that from you. You were the instructional model for that in terms of relationships. Now, when we see true separation anxiety, what that is that the child has not internalized and mentalized the caregiver. So out of sight really is out of mind. Out of sight is really like they're gone. And worse than that for the kid is, I don't have a sense that my parent, when they go off to work, is holding me in their mind, that they're thinking about me all day. So that's part of mentalizing as well. So when you have a low-functioning, developmentally functioning client who comes through high-functioning schizophrenic, let's say, or just low in terms of psychological development, comes in quiet, you're expecting them to show up like a normal person would and use their words and verbal skills, but they're undeveloped, so they're just kind of sitting there like staring at you all the time, and they're like the hard clients, they're kind of frustrating, because they're not performing, they're not doing the client role, the patient role. You're like, there's rules to this game. Like, you're supposed to do all these things and make me feel like a therapist, and on and on. It's supposed to be a back and forth dialogue. But, so those clients, and so they're harder to sit with. One, they're hard because our expectation is holding them up at a higher developmental level because of their SES, socioeconomic status might be, or their age might look like, and they're good looking, like, hey, you should be able to connect here. So I've worked with a lot of these ones that are slow to develop, actually, and then they're mistrustful. They are mistrustful. And then after about a year and a half, there's more and more trust. And then I'm with some of these clients, I'll actually take them to meet other therapists because they're leveraging off the secure base in our relationship to meet these other ones, other therapists that are like art therapists or yoga instructors or psychiatrists even. And so we're leveraging off of the secure base we have. And then I remember this client, he went off to San Diego, and then from Sacramento, and then a year and a half later, he calls me and he says, I've been thinking about you quite a bit. And that is that he mentalized me, finally. That wasn't there in the beginning for a long time. So anyway, that's such like whatever almost, but it is super important in terms of assessing psychological development. So in my program, I have my staff sometimes in between sessions send a little text out to the client just saying, hey, I was thinking about you and this popped up, can't wait to see you next week. I've been carrying you in my mind in between sessions. The other thing that happens, is that through secure attachment, a positive internal working model gets built and developed. And the internal working model, so we've talked about relationships a little bit, haven't got much into the neurobiology yet, but those are regulatory systems. And then the internal working model is the psychological filter that kind of is always at work. It's at work right now when we're in this room, So it's, it's how I see myself. It's how I think others see me, and it's how I come to expect what I can ask from the world or what is going to happen within our relationships. And everyone in this room and globally has a different experience of that. Some are like, it's not okay for me to receive in relationships. Others are like, it's fine for me to receive in relationships. Others are like, I should be always receiving in relationships, right? Some have an idea of what it's like to listen to a bald-headed 43-year-old guy who's lecturing, like, well, if you come from a family history with bald-headed lecturers who are lecturing very angrily and full of shame and using shame as a weapon to control behavior, Sitting in the room, it activates neurobiology of the sympathetic arousal and cortisol just sitting here, you know. And also, I don't like myself in this moment, and I don't know why and where this comes from, because it's so bedded in the unconscious internal working model, and I'll talk more about that as we go. So this is just laying some framework. So regulatory systems, I want you guys to think about. So I said at the beginning, what underpins addiction? And a vulnerability to stress. Stress vulnerability, said more clinically, affect dysregulation. Right? So when you're reading through the literature, affect dysregulation just means I struggle to deal with stress. Now, stress can be a lot of different things. It could be boredom, it could be depression, it could be anxiety, which is just a nice clinical term for fear. It could be all kinds of things. People are one of our biggest regulatory systems in our life. People. People regulate us for better or for worse. I want you guys all to just kind of, for a second, go inward and just think about all the people in your life, or hope to find a couple of people in your life that when you're around them, you actually feel energized, you feel good about yourself, you feel uplifted, you feel like you want to take on something that's even more creative, like it enhances your drive, it makes you want to give to others maybe. Who are those people in your life that just build you up? And they don't even have to say a word, right? As you think about them, they could just be in your company. No cognitive behavioral therapy is needed. The relationship. Now think about those folks in your life that when you're around them are toxic, they're draining, they're depleting, they're depressing, you need to take a nap, you feel them in your gut, you don't just think about them. Now, which colleagues, family members, in-laws, classmates, do you see what I'm saying? And even the mental representation of them has an effect probably to some degree. I mean, now we can change our narrative. If we started to say, someone please share a story of the person that uplifts you the most and the last time you just were with them and what that felt like. We would all start to kind of be moved by that. And then the opposite is true too about the depletion. My grandmother's 98 years old. I'll jump to that. My grandmother's 98 years old, and when my partner Angela, Dr. Angela, an enchanter, and I go into her care facility, we look at her and she's like this because she doesn't see us coming, right? She's in the room. She's like this. Now, she's not vegetative at all. She's cognitive all there, but she's just bored and depressed, and she's out of it, you know, like in terms of psychologically. And we walk in, and especially bring the kids, and she's like this. How are you guys doing? You know, and we talk through. Now here's how powerful this is. We start to talk about whatever's going on. I'm arguing right now that her mood gets lifted faster than any drug can lift it and with less side effects. From the street, from the pharmacy. And if I said, Grandma, you're 98, I want you to die because I've always hated you, she would hit a depression faster than any depressant would ever put it in her body, and it would never drive her down, as deep as the relationship would. We feel the best feelings and the worst feelings in our life within relationships. And relationships, so now you got it, are a regulatory system in our life. So check out your regulatory system of relationships and kind of inventory that as you go through the day. Because that's what I'm doing, is this is a education, but also an introspection, that we want to be a little bit more mindful of how do we show up and how are people showing up and how do we utilize the space in our social synapse, the space between us in relationships that are regulating our mind and body. Another example of that was when I was, 11 years old, I was climbing a tree in my front yard, and I was scaling out off of this branch just to kind of go out, and my neighbors and I, or my friends, would let go and then fall and then do it again. And we're hot lapping this tree. Fall, climb the tree, go out, fall. And one time I slipped, so then on the fall I came down to stop the fall and broke my wrist. And I broke it in two spots, here and there. So this bone was floating. And my mom took me to the hospital, and do you guys remember those finger handcuffs as a kid? The more you pull on them, the tighter they get. The doctor had those made out of chicken wire hanging from something, and so every finger had the chicken wire handcuffs going on. And then they put some weights on this to pop it back in place. I'm an 11-year-old boy, and I'm like, all right. And so I'm just trying to be a big boy, tough soldier through this, shaking and crying on the inside, not on the outside. And then the doctor goes to numb the wrist with medicine, and I feel the tip of the needle scraping on the bone. Now I'm shaking and sweating, and I'm like tearing up. And my mom puts her hand on me, and right away I was calm. And I felt that, like, again, how fast that occurred for me. So those are happening all the time. Now, I'm talking about right now some real-life adult examples in adult relationships. But think about it when we're growing up or our clients are growing up in those families that are not consistent for them, that are abusive to them, that are neglectful to them, they're dismissive to them, they're not responding to them. And early on and then throughout. And then they attract those types of relationships in their young adult life and then adult life. And they just keep playing out what's familiar until they hit bottom with that, or therapies come in to reorganize and rewrite their internal working model and how to approach relationships in a healthy way. So the development of the self. When we grow up, so this is us growing up, we have a broad array of capacity. And then this is supposed to represent a caregiver's array of capacity. Now, I just wrote an article on codependency that's going to be published in the national run of Counselor magazine for the July and August edition as the feature article on the development of codependency. So that's really kind of what this is about to some degree, just FYI. So we already talked about, kid grows up, they have some basic needs, some food, and then the parent has the capacity to feed, right, when they're hungry. Parent has the capacity to feed. Then maybe part of a kid's need and capacity is I have a need to play. Caregiver has a capacity to play. And then maybe I would like to roll around and be physical and sensory motor. And parent has a capacity for that. So that all that stuff gets integrated for this developing self. All those pieces get integrated into the self. Now, maybe though I'm left as a child left or right brain dominant, but my caregiver's left brain dominant. Maybe I'm relationally, emotionally porous and sensitive, and my caregiver's dismissive and alcoholic or drug addicted or narcissistic and just preoccupied with something else, and they're not connected to my internal world. So what happens to these parts of me that the caregiver can't respond to? What happens is my theoretical or rhetorical question. But I know that the other 174 people across the country that are watching this right now can't respond, so I'll go ahead and answer the question. And that is, we have to split off from that. So if I'm emotionally sensitive and I keep turning to a caregiver that doesn't have the time of day for me, and when I look them in the eye and I'm not the gleam in their eye, but I'm the thing they're tolerating, it's a sense of shame. And that sense of shame then makes me feel like I'm the only one that feels sensitivity, so I must be the one in the family that's crazy. And it certainly reinforces I should not connect to this part of me because it's an injury when I do. And it's certainly an injury within relationships, which are the most important thing in my life. So now I need to partition that away, harbor it aside, stuff it down, disassociate it from it, or split off from that. Now that's going to take a lot of psychological energy over time. And when I start to get tired trying to use psychological energy to push that away, then here comes the drug use, here comes the sex use, here comes the gambling use, here comes the work addiction, the food addictions, and whatever the addictions are, because underneath addictions is also really about avoidance. It's all about an avoidance issue. So now I get to avoid these parts of me that I don't like and do whatever it takes. So now that I have to split off to fit into the attachment relationship, like Bowlby says, for better or for worse, attachment's a biological necessity, and I need to do whatever it takes to stay in the light of my caregiver. So if they only got these pieces of capacity, I'm going to come over here and do it and split off from these other parts of me. Now, I was working with a 14-year-old guy, and so I said earlier the use of self is a really good instrument as a diagnostic tool. to assess and just kind of listen to what your gut's telling you and let that inform you. So I was sitting with this 14-year-old young guy, and by the third session, I thought, what a sitting up straight, articulate, beautifully articulating, mature young 14-year-old. And I was like, I should not be having this experience with the 14-year-old. He should be a little bit more like, I don't want to be here. This is goofy. I don't even understand what you just said. Like, can you say that again? Do you want to hear about the latest Nintendo video game or what drink I had at Jamba Juice? Right? And, you know, kind of a little bit more all over the place and not so contained, flat affect, narrow restriction of a range of emotion, and presenting in an intellectual, you know, proper way. That's not a 14-year-old. I actually went through this with that 14-year-old, and I do this with a lot of families. And he says to me, so mom's a parole officer and dad is always in the garage working on the car. So when he has stress in his life and he takes it to his father's, who he wants to always take it to, when he takes it to his father, the father's response is like, I don't want to hear all that stuff. And when the kid's like, hey dad, let me tell you about my new lizard I found and I want to play and be happy and engage in this way and let you see how I do novelty seeking these days and how rewarding it is that I'm discovering life and found this lizard, the dad's like, yeah, I don't have time for that. But when the kid comes up and says, hey dad, I really wanted to talk with you, when the energy's out, when the affect is out and it's just flat affect, and dad, I want to talk to you about the car you're working on, and I want to talk to you a little bit about my grades, then the dad's all like dog on point, man, like, all right, talk. And so the kid has learned to split off from all these other parts of himself and just be that organization. So this is how personality gets put together. Now we know most of temperament's just, you're born with temperament. You're just born with temperament. But here is how personality gets developed. Parts of us get integrated or split off and fragmented. There's how security happens and insecurity happens. Now the worst dynamic, I mean, we had to work on laughter within sessions. You know, like I don't work on laughter as a therapeutic goal with clients. We had to work on laughter. Allowing that to be okay, because when he would laugh, it felt insecure and uncomfortable because it was kind of a little bit of a shaming experience with dad. Dad did not vocally shame him for laughing, but dad didn't attune to the laughter and the need of the kid to laugh, and that's a subtle trauma. Lack of attunement is a subtle trauma. We've all been taught about the big T trauma, abuse, physical abuse, sexual abuse, rape. That's big T trauma. Little t trauma is the lack of attunement. And there's a lot of data out there from Dan Siegel that Dr. Grimes talked about and cited earlier. All right, so you guys are with me on this development. Then the next piece to this, and really fuels codependency and split off from self, is this. All right, now I got to split off from parts of myself because my caregiver doesn't have this broad array. They only offer me this, so I'm going to stay right here and split off from these other pieces. The next dynamic is this. The kid has to go, how do I take care of my caregiver so they can take care of me? Narcissistic parent, axis 2, cluster B parent, bipolar acting out parent, depressed parent, or normal parent, but there's just been a significant death in the family and a job loss in the family, which is really creating a crisis in the family, and I was just born into it. So, you know, 2008 in the economic crisis, I was wondering, like, how many kids are going to be really affected by this because, you know, they got to move to another state and the parents are super stressed, they're broke, they might be fighting in the family. So it's not like, you know, they were bad, it's just dealing and adjusting to a situation where the kid's like, second maybe, you know, like, here's your food. We got to get a job because there's some priorities that need to happen. Certainly the priority for the addict is what? I need to figure out the next high, the next drink, and how to cover it up. The priority for the narcissist is how can I expand my ego and let you guys all adore and celebrate me, on and on. So what ends up happening in that system is the kid has to become hyper-vigilant to clock the parent's caregiving, the caregiver's needs. Do they need a laugh? Do they need to be left alone? Do they need me to engage? Do they need me to perform academically and show them a whole bunch of straight A's and great scores on my, you know, in sports? What do they need? Because I need to now take care of them so that they can take care of me. And that's the codependent, that's how codependency is developed. We're not born codependent. And it's not just a function of being in a relationship with an alcoholic. It is a childhood, family of origin, family history experience. 9 times out of 10. There's always the exception. Okay. Now I want to get into a little bit of a play on the, I think Dr. Grimes alluded to it in the introduction, that one of the things I wrote about with interpersonal biology to the introduction to this presentation today is, my argument is this: there's no separating relationships from neurobiology and from psychology, and that there's no distinction between mental health and addiction or addictive disorders. That distinction was made by county funding. You guys with me? The distinction between a mental health issue and an addiction issue is about money. It's not a, that's a relative reality that we all subscribe to, and I think we have to lose that. So my argument is it's all the same, built on affect dysregulation. I'm outside of the window of tolerance to be able to sit with what I'm feeling, so I act out in an expansive ego in a narcissistic way, or in an addiction where I fuse with this drug that makes me feel powerful and regulated. What's the difference? There's not much. There's not much. Okay, so let's go to a relationship again. When we're born, we all have genes for, there's some regulatory systems. So I already said how our relationship's a regulatory system. Grandma's regulated when I see her by me, for better or for worse. When I see Angela, after she has a hard day at work and I have a hard day at work, my mood changes. My mood changes. So within a relationship in the early years, so now to the neurobiology, the dopamine system is developing. And I'm going to talk about the dopamine system today because the topic's about addiction. And we all have been kind of trained that the peak of intoxication is dopamine firing. It's also an opiate firing too. So you can be drunk. When you get to the peak of intoxication with alcohol, and that's a GABA system phenomenon. But it's also, the peak of intoxication is also dopamine, but also an opiate firing as well. The mu and kappa opiate receptors firing in the brain. So when the dopamine, or if you're reading the literature, the hedonic system, the pleasure system, the mesolimbic system is developing, the dopamine system is developing in a relationship. When there is shame, what the research is showing us is shame activates what's called apoptosis, or programmed cell death, and starts to contract the development of the dopamine system for the child. Now right there, those of you who are deep into the addiction field and have been trained for a long time about the dopamine system can already see a link right there, right? Wow, I grew up in a family of origin issue that got in the way of my neurobiological development, because the relationship, the social affected the biopsychosocial. The social affected the dopamine system in my brain, and now I have deficiency in dopamine production. And what's tethered to this psychologically is a desire psychologically to be unseen. So the position becomes like this. Please don't look at me. Please don't talk to me. Please don't get into my internal world, because that might be scary to me. Biopsychosocial. There's no way to separate that. So if you're working with a psychiatrist or that's pharmacologically biased, that this person has a dopamine issue and they provide Provigil or a dopamine reuptake inhibitor or something like that, we have to think about it also as, well, what's going on within the relationships that doesn't allow them to have the sense of being seen or feeling felt. And then how do we offer the instructional relationship within therapy to help them be seen? I would argue that the goal of psychotherapy over time is that the client has the experience of allowing them to be seen, to shed their vulnerability, and the core of addictions is certainly shame, if we looked at just an affective state. So it's them to stand in their shame. Shame is that one thing that any of you who've been committed to psychotherapy or personal growth and psychological development over time, the shame is that one thing you've never shared yet. So when I'm out there giving lectures, show of hands, how many of you have been in therapy or 12-step meetings or personal growth and still have that one thing that you haven't shared yet, 70% of the crowd shares their hand, even though they're still in a committed to personal growth process and program. And I used to be one that would raise my hand up until about 3 years ago, and I was like, I need to now have the courage to heal and stand more in my vulnerability about some of my shame, and then, you know, kind of went and shared my shame. And then I was like, look up at my therapist. She's like, I admire your courage for making it through it all with that, you know, like through life and having that inside of you. And I was like, that's it? You're supposed to like kick me out of here and like not like me and think I'm, you know, silly and stupid and wrong and immoral and all that kind of stuff. And I was like, man, I should have let that go a long time ago. So hopefully like that gives you some permission to heal. So when we talk about neurons in the brain, we all know about the blooming process of neurons in the early years and the pruning process. So what I've just described is how the environment prunes the dopamine system. It prunes it. So when Bowlby said, for better or for worse, we're going to attach and we're going to split off from those parts of ourself that are not allowed in the attachment relationship, that's just pruning. Neurobiologically, our brain's networking to let go of those things that are not allowed. And when there's shame, certainly the dopamine system is pruning as well. I won't talk about that one. So I'll just tie this into drugs a little bit now. Many of you were familiar with the OxyContin epidemic we were experiencing 3 years ago, 4 years ago, 5 years ago, and 6 years ago. 50% of my practice were young adults using and abusing OxyContin. Purdue Pharma, finally the manufacturer, came out as they, when they produced this drug, by the way, they were marketing it to physicians saying it is no more addicting than Vicodin. And clearly that's not the case. So they got sued, they got their hands slapped, and they actually got very genius and brilliant in terms of science and medicine, and that was they created a tamper-proof medicine to some degree, mostly. And that was they made it so that this pill, when chopped up, could not be injected. You know, they would chop it up before and add water to it, put it in a syringe and shoot it in their arm. They made it so if you added water to it, it would like kind of gel up, you know, so that prevented that. That's brilliant. We need that. Certainly with some of those Zohydro coming out and some of these other potent opiate agonist medicines. They made it so that when someone tried to chop it up and snort it, that it wouldn't turn into a powder, that it would just kind of stay chunky. It was super hard to pull off. So and then it also made it hard to smoke as well. So then what happened to the OxyContin addicts? They went to Opana, and then they went to heroin. And in Sacramento, where I'm from, during that 3-year, 4-year, 5-year, and 6-year window where these folks were coming through, it was white middle class, upper middle class, people paying $80 a pill. It was not the old broke socioeconomic status. Now, when I grew up in South Sacramento in the 1980s, it was heroin addicts were people who spent time at San Quentin. The drug was coming from the Mexican mafia from Mexico up, you know, right up to California, and then it was, you know, distributed at least in my region from that route. But the profile was certainly low socioeconomic status and kind of the grad school user of drugs, you know. Today we're seeing so many young people that are just, there's no profile. It's just, there's no stereotype to heroin use today. So that's what we're dealing with. Now heroin is activating what? What's the reward of heroin in the brain for the heroin user? Because this is where we are now, right? We're dealing with this issue, and it's in its early legs, so there's going to be a lot of years of us dealing with this heroin addiction. Well, certainly it's part of the dopamine system, but it's also the opiate system as well. So just a little bit of some brain orientation. The ventral tegmental right here is where a lot of dopamine fibers are stored. Now, back to the triune brain, which was by Macklin. I remember who the person was that coined the triune brain. Down here, the lower in the brain is more regulatory functioning, heart rate, that sort of thing, breathing, heart rate, organs. The middle of the brain is more our midbrain is our social brain, our emotional brain, And then the top is, this is a gross simplification for sure. The top is more our reflective, abstract part of our brain, reasoning. What are the consequences if I do this? So there's many bundles and neurofibers of dopamine in this system, and then the route is that it then goes to the nucleus accumbens, and then when the impulse, the drive, the I want this thing hits the prefrontal cortex asks the question, what are the consequences going to be? Or starts to list what the consequences are going to be, which then signals a firing back down to say, maybe we're not going to do that. My name is Tiger Woods, and yeah, maybe I'm not going to go out on a date tonight with a bunch of women I don't know or I pay a lot of money for, right? That's addiction, right? Even though we're talking about chemical dependency, that's addiction. So so it's a bottom-up hijacking, and when you read in literature bottom-up hijacking, that's an actual psychological concept. That means that the bottom lower systems are beating up. We don't have enough of braking system of top-down regulation, that we're being hijacked by bottom-up hijacking versus top-down regulation. Their thought is that there's some missing link right here for addicts, that there's a little bit of a missing link there. Right? And what happens with the system around the addicts? They're like, can't you see the problem? Can't you see if you keep doing this? Where is your prefrontal cortex? Because you're deficient of prefrontal cortex, I'm going to be your prefrontal cortex and tell you what's going to happen if you keep doing this. And you know, it's funny, like that compensation, because what happens when you're sitting with disassociated, split off, repressed clients? You're like, I think I'd actually be upset by that, right? They're not feeling their feelings. You're like, well, I would be actually sad about that, or I'd be happy about that. You're kind of role modeling. You're compensating for the piece that's not there for them. Now, this is just another thing I want to let you know that you can use tomorrow with clients. And I found this really interesting. I was reading through a lot of journal articles. I have a research assistant that was helping me put together my book. This is my commercial, the book that I have that's on my website at recoveryhappens.com. And so Jeff was helping me. And what I found was that people who have experienced trauma, so this part of the brain right here, the locus ceruleus, produces noradrenaline just by default. That's what that does, which is heart rate, breathing, a little bit of arousal. Not pleasurable arousal, but motor arousal, energy, just energy. People who have a history of trauma, big T trauma, not little t trauma. Little t trauma beats up on dopamine for sure, but big T trauma is what's beating up on this. What happens is this starts to produce too much noradrenaline. So baseline for people with trauma then becomes too much noradrenaline, which is overly aroused sympathetic nervous system. No parasympathetic tone. In new stress and vulnerable situations, I stress faster than other people do. Heart rate goes higher and takes longer to come down. Everyone in the new situations, heart rate's going to go up. So theirs goes up higher and takes longer to come down. And so, you know, so they're kind of walking without knowing it, right? They're just walking without knowing it in this kind of state. And of course, they're going to adjust to it and adapt to it, because that's what are you going to do? What happens when people use OxyContin or heroin, and this became interesting to me, just putting pieces together, is it puts a dam in front of the locus ceruleus, so that when the locus ceruleus is releasing, it's now restricted by the opiate drug. Now, therein lies a really good mechanistic approach to understanding self-medication for someone that's had a lot of trauma. They're walking around flooded and, of course, affect dysregulated, but also neurobiologically flooded, and they slow it down and get their needs met to some degree by the opiate drug. Make sense with me on that? Nod your heads back there in cyberspace, please. Thank you. All right. So here's what happens with withdrawal. So now the person's shooting up, snorting opiates, shooting up opiates. It builds a bigger dam, and the locus ceruleus tries to just produce more and more and more to beat down that dam. And every time they shoot up, their locus ceruleus is producing more, but can't get through the dam. Then we come along as great interventionists, legal system, therapist, family system, saying, it's time to stop. or they check into your treatment program, it's time to stop. Now, if unmedicated with opiate replacement medicines, guess what happens? That dam breaks and that locus ceruleus just fires noradrenaline everywhere. And that's where when you're done with the withdrawal, that's what you're dealing with. So now they're sweating, they have vomit, they have diarrhea, their heart is racing, their skin is pale. They are flooded with noradrenaline. And it's pretty amazing to sit with addicts in withdrawal. So, there's a wonderful medicine, and I'm going to say it's a wonderful medicine called buprenorphine. And, sadly, people are not up to date with the science behind it, but doctors are, but recovering communities not. And it's thought of as they're still using an opiate, and when in fact it's not. You're not going to overdose on buprenorphine. If you're on buprenorphine and you shoot up heroin, the heroin's not going to work because the mu-opiate receptors are just jammed with the buprenorphine, and nothing's going to penetrate that. They're not intoxicated, so it's like if you use heroin or OxyContin, if you picture the opiate receptors in the brain like this door, when someone uses the opiate drugs, that door swings wide open and they're intoxicated. What buprenorphine does is allows that door to open with the hotel chain lock right there, so it opens up a little bit. Enough to be regulated, but not enough to get all intoxicated. So the only drug that can push through the buprenorphine, just so you know, is fentanyl. And now we're certainly seeing and hearing, as of even 3 days ago on my website I was reading, when I say on my website, the top left-hand corner of my website is updated every day by news feeds on the latest research on teen and young adult drug addiction. So I just turn to my website to inform myself nowadays, besides my clients. So so fentanyl is an issue. That's a real issue. But if you have clients and patients on buprenorphine or Suboxone or Subutex, fentanyl will push that off of the KEPA receptor. If they're using heroin, it won't. Buprenorphine is going to work. Where was I going with that? So that's what you're dealing with opiate addiction withdrawal. Now, I've shared this with clients, session 1, session 2, and I've had many, many people now, and my staff have had many people now do this. What do you think happens when you explain this to a client? What have you just given them permission to do that maybe they didn't feel in other therapeutic relationships? You've given them permission to say, I've never talked about this with anybody else, but my trauma occurred when I was such and such years old. So this is a really powerful presentation to give to your clients. I'm going to say a couple of other things. I'm going to have to track time here, so. My argument on substance use is that the name of the drug is an illusion. And sadly, we have prejudice and bias about drugs that get in the way of us being most therapeutic and most effective in being therapeutic. We already have a bias on what's legal and what's not. That's a bias we all have a prejudice about. There are plenty of legal medicines that are absolutely harmful. There are probably a lot of illegal drugs that might not necessarily be harmful. We have bias. If you get a phone call, I want to ask you to think about going inward for a minute, and you get a call right now from the police, and they've popped your child at the park smoking marijuana, what's your visceral reaction? Just personally inventory that. You get a call from the police, your kid just got popped with heroin. What's your visceral reaction to that? See the prejudice? See the bias? Right? Now that bias is important because we need to get to where it's the same across the board. Because what happens is we go, it's only marijuana. So we'll talk about this. Oh, heroin, you're going into a program, right? So there's a bias. And what I'm saying is we need to not be in the bias. We need to intervene in cancer at stage 1 and not stage 4. And I'm not saying that heroin's the stage 4, but I'm just saying we need to intervene early. I'm not biased. If my clients come in and they're like, I smoke weed every single day, Jon Daily, 7 days a week, and I'm going to quit smoking weed, and I'll let you know how I do next week, and they come in and they're like, I didn't smoke weed 7 days a week, But on Monday I did ecstasy, and on Tuesday I did Vicodin, and on Thursday I did alcohol, and to me I'm like, it didn't get better and it didn't get worse. It stayed the same. You stood in your relationship, pathological relationship, to intoxication. You're still active in your addiction. You're still active in it. Because they're not hooked on whatever that drug is they present. What happens to the pot user who's smoking weed every day? And that's my clients, right? They're smoking weed every day, 4 times a day. And you ask them, how often do you drink? I don't drink for intoxication, but maybe twice a month. And then all of a sudden probation jumps in, family jumps in, drug programs jump in, and they're not going to smoke weed because it's detectable for a long time. And all of a sudden what happens? That alcohol use increases, and maybe they'll add some Vicodin to it as well. So they're not hooked on marijuana, they're hooked on intoxication, and that's the thing. If you guys like ice cream and mint chip is your favorite, or whatever your favorite is, visceral, you can inventory, you don't have to say it out loud. You go to Baskin Robbins or whatever the best gelato or ice cream parlor is, and they're out of mint chip. Do you think you're walking out? Some of you are like, yeah, I don't have a pathological relation to a mint chip or ice cream. But most people are going to choose a different flavor. Now, I'm not saying you're all ice cream addicted, but that's how it is for addicts. They are hooked on intoxication. They're not hooked on the flavor of marijuana or heroin or whatever. And there are plenty of people who are going to try marijuana and not get addicted. There's plenty of addicts, self-assessed, self-diagnosed addicts who've tried heroin, and they're like, I didn't like it. Plenty of self-assessed, diagnosed addicts who are like, I've tried cocaine and I hated it. And others like, I loved it, but alcohol is my thing, So that's the thing. We got to lose the bias. I think there's an over-minimization of one drug versus the next drug. Now, I know what the arguments are about heroin versus marijuana. I do. But I also know that you don't know how marijuana truly affects the brain in terms of neurological development and coping skills development and psychological development and relationship development if you use it at a young age. It stops it all to some degree. It doesn't stop it all, but it slows it down. And yeah, heroin has the physical withdrawal and all those pieces I just talked about in the brain. Marijuana has withdrawal too, and doctors are certainly looking at using Neurontin now and gabapentin to manage marijuana withdrawal. So experimentation is a one-time event. Misuse is infrequent use for the purpose of intoxication. But back to the relationship to intoxication, here's what I do clinically. These people will let drugs go if they get in trouble. If drugs create a consequence, these people let it go. 97% of the kids who go through high school are going to try something. And if a consequence occurs, for these people, they let it go. For here, they're going to go on YouTube and try to figure out ways to beat the drug screen. They're going to go, what's the next best thing to marijuana? K2 spice, or okay. So it's protecting and holding on to a pathological relationship to intoxication. It's that relationship you had with that girlfriend or boyfriend when you were young and everyone's like, you need to ditch that person. And you're like, no, it's mine. I'm not seeing her anymore. I'm not seeing him anymore. Sneaking out at night, going to meet up. It's an unhealthy relationship to intoxication. I'm running low on time. I have about 15 minutes, 10?
Yeah, you can go another 20.
Oh, all right. It's on now. Okay. So I want you to know that's this. And misuse is not weekends. Misuse is Halloween, April 20th, New Year's Eve, graduation, spring break, that sort of thing. Average age of first intoxication is 12 years old, and that's not earth-breaking. It's been that way for the last decade. What's earth-shaking is that THC, in my day, before I got in recovery, smoking marijuana in the 80s, was up to 5% THC back then. In the 70s, it was 3%. In the 60s, it was a half to 1%, 2%. And marijuana today is, as a bud, is 20-something%. But in the last 2 years, we're seeing wax, dabs, and butter, which is 70%, and we're seeing psychotic breaks. In this room, show of hands of how many of you have had clients that have had psychotic breaks from wax, dabs, or butter? 1, 2, no, okay. It's a phenomenon that we're seeing occur, and they're not schizophrenic, just a psychotic break. There's a difference between psychosis and schizophrenia. So substance abuse is using despite negative consequences. They're holding on to the relationship to intoxication. Young people's values start to change. Family was important, school was important, but now what's important is how do I get my next high? I don't care as much about sports. I don't care as much about school. And so that starts to happen. It inhibits the development of emotional coping skills. We know that in the second half of adolescence and early young adulthood, you're supposed to have stress and anxiety. And I already said earlier, stress is the enemy of mental health issues and addictive disorders. So the first half is not that complicated. You know, we're going to hang out and, you know, talk on the phone and everything's paid for and meet up at Jamba Juice and Starbucks and Chipotle and what's the latest movie? Pete, do you want to go play some basketball? Angela, what are you doing? Have you heard this new album? You know, it's just, you know, Tiffany, what's happening over in your neck of the woods? It's just, you know, it's kind of easy. Second half of adolescence is, how do I ask them out on a date? Will they ask me out on a date? Can I get a car? Can I pay for it? Do I have enough courage and negotiation skills to tell my friends they need to chip in on some gas if they get in the car and go for a ride with me? How do I get a job? Can I do good enough at the job? How do I get into college? It now shifts in the second half. That's just fine. That's normal adolescence. That's what, in the absence of early childhood attachment issues, family trauma with histories of depression, narcissism, addictions, physical abuse. We're just talking about normal adolescence right now. So they have this anxiety, and what happens naturally is within that anxiety, we pick up the phone and we call people, ask them what they're doing, talk about what's happening, maybe we get invited to do something together. And in that situation, it soothes us. Just kind of naturally. My boredom's starting to go away. My anxiety's kind of going away a little bit, right? And I'm learning pro-social skills by talking and learning from each other. Now, with this anxiety that's happening, that's occurring because now it's like life isn't just my parents telling me what to do. Life is, it's on my shoulders to ask this person out on a date or to tell them not to drive with me in the car or drive in my car under the influence or don't smoke weed in the back seat or can I get a job, hold down the job, get into college, graduate college. There's stress because the question now is about, am I adequate enough? Do I have mastery? So when Erickson was talking about identity development, a big part of that underneath it was mastery. So there's kids are just smacked in the second half of adolescence and young adulthood with the sense of adequacy, and that's stress. Now, if I don't do all the healthy things to manage that, reach out, turn to people, find new activities, grow socially, and I smoke weed, so that, well, let me just back up, that tension, that anxiety is tension, which intrinsically, unconsciously seeks relief. It says we need relief, and then that's where we do the healthy things to relieve it. But if I smoke weed, what happens to my tension? If I drink alcohol, what happens to my tension? The good side of the alcohol, my tension goes away. The good side of the weed, my tension goes away. The good side of the heroin, my tension goes away. The bad side of the other side of that sword, the other side of that coin, my tension goes away. And so then goes away my intrinsic drive and desire to grow and grow psychologically, neurobiologically, and relationally. Because if I'm stoned, I'm like this. Now, if I'm standing and feeling my authentic stress and tension and boredom, I'm like restless and whatever, and then I'm like, hey, Pete, you want to go play basketball? And right there, now I'm just talking is relieving. Turning to a relationship is relieving. Pete says yes, and we go play it. Now we're moving our body. And then he teaches me a new something on the basketball court. And now that's something new I'm going to work on now when I'm bored, maybe. And then we go to Angela's house and on. And now what's happened is I've learned even more social skills. I've learned other coping skills. Turn to the relationship, reinforced by the relationship to soothe. A lot happens. But if I smoke weed, lost opportunities to explore those other parts of my personal growth. So that term arrested development is what I just said. Let me switch, fast forward through some of this here. So values change, emotional growth gets distorted, certainly an attitude of I don't care. Addictions, everything that I just said, but there's more obsession around it, preoccupation, craving, and loss of control. And loss of control is when the client is telling you, of course, hey, it'll be different this time, I'm setting limits, or I'm not going to use it, and they can't follow through with their limits. Food addiction, right? I'm not going to hit the buffet, and then I hit the buffet, but I'm only going to have a little bit, and there's more. Gambling addiction, loss of control, I'm only going to gamble $20, lose the $20, anxiety goes up, bottom-up hijacking, not thinking about the consequences of the last time you got scolded at home for losing the money and guilt and shame that you had that was healthy and appropriate. And then you go to the ATM and you gamble another 60 bucks, and then you drive home going, man, I shouldn't have done it. Now you're beating up on yourself. And the next thing you know, if this is an addiction, you're kind of down on yourself, and the next payday comes along and it ignites preoccupation and obsession. Well, it'll be different this time, and then that cycle continues to repeat and play out. What supports denial is when people start using, they increasingly hang out with more and more people that do the same thing. That's just how it goes. And the younger you are, the more likely that's happening. It offers stress relief. It offers acceptance into social needs being met. You know, in some of the schools where the kids go that I work with, and it's probably everywhere, but there could be some niche-y stuff going on, and there could be some socioeconomic status stuff going on, you know, and the need to belong and fit in is a drive, you know, that we long for with our peers. We're like, all right, parents, you love me, I get it. Now let me try with my peers, and now I'm struggling with that. Someone knocks on the door of drug culture with a bag of pills, a bag of marijuana, or a six-pack. The response isn't about the clothing and how you talk and what music you listen to, and it's come on in. Let me introduce you to everybody. Let's all share in this intoxication. And it's a sense of family and it's a sense of community. And that's certainly one of the hooks for a lot of young people. Let me just fast forward a little bit.